welcome, everyone. Thank you all for joining us today. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Serfati, and I'm here, like every month, with Dr. Hilary Humans, who coordinates and moderates this series with me. And our guest speakers today are Dr. Girish Gandikota, Dr. Alexia Lopes, and Dr. Elena Drakonaki. It's hard to pronounce the names, but I did my best. Anyway, so this session will focus on rheumatology. The speakers will present their cases, and at the end, we will have a Q&A session. If you have any questions at any time during their presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. And just a quick reminder, attendees have not been given the permission to screen record any of these presentations as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. And we thank you for your understanding. And with that, Hilary will kick off the session.
Okay, it's my pleasure to introduce Dr. Elena Drakonaki, who's a clinical radiologist and assistant professor of anatomy at the Medical School of the University of Crete in Greece. She trained in radiology as a resident at the University Hospital of Heraklion and as a musculoskeletal and PET CT fellow at the Oxford Nuffield Orthopedic Center and the Oxford Churchill Cancer Center. She's been a visiting lecturer of anatomy at the European University Medical School in Cyprus and has worked as a radiology consultant in the NHS system and private sector in Greece and the UK. She's the current chairperson of the Educational Committee of the ESSR, managing the ESSR diploma in MSK Radiology. She's also the vice chair of the Hellenic Society of Skeletal Radiology and an active member of the ESSR intervention and ultrasound subcommittees. She's been a faculty member at several European meetings, including ultrasound courses, and has delivered numerous invited lectures at meetings and workshops. She's published extensively, and her research interests are in musculoskeletal ultrasound and intervention, imaging anatomy, orbital imaging, MRI for thalassemia, sarcoma, and ultrasound elastography. Okay, share your screen, Elena.
So, thank you for this kind introduction. And thank you. It's an honor for me to be here today. Thank you, Aline and Hilary, for inviting me. So can you see the screen?
Yes, it is.
Yeah, okay. Sorry for this delay. So thank you for the invitation. And as said, I'm based in Crete, which is an island at the south of Greece, and I'm affiliated to the local university, which also holds an international program in medicine in English. So the case that I'm going to present today, I think it is an interesting case because it shows that ultrasound findings can be the key to suggested diagnosis, which is quite rare. So this is a 39-year-old man who presented with painless asymmetric soft tissue swelling at the ankles and feet. The left side was more pronounced than the right. And on clinical examination at the hospital, that was unremarkable. No fever, no signs of infection or heart failure, no history of any systematic disease. It was negative. And he was referred to the ultrasound department of our hospital to check for superficial vein insufficiency and DVT. And indeed, we had the ultrasound, the Doppler ultrasound, which showed no vein thrombosis or insufficiency. And then we tried to look at the soft tissue. And what was evident there when we scanned the soft tissue of the ankle, this is the medial malleolus, and you can see that there is extensive subcutaneous fluid collections in keeping with cellulitis. And there is also mild effusion around the tibialis posterior tendon at the level of the malleolus and at the more distal level. But what was quite interesting and unusual was the fact that there was increased vascularity inside the subcutaneous fat, whereas there was no neovascularity inside the tendons or at the tendon sheaths and no sign of synovitis. And when we looked at the joints, there was just a mild effusion, just a minimal amount of fluid in the ankle joint and no significant effusion and definitely no synovitis in any of the joints of the midfoot or the ankle. So to sum up, there was no synovitis or effusion or significant effusion in the joints, no systematic symptoms or disease, any kind of history, and there was only mild tendon sheath effusion, and what was more evident was hypervascular subcutaneous cellulitis. So the radiologist asked for a chest X-ray, and we did an AP chest X-ray, which is this one here. And it shows bilateral symmetrical hilar enlargement and no evidence of lung field abnormality. And with these findings, we further asked for a CT of the lungs, which again show the presence of enlarged mediastinal nodes and hilar lymphadenopathy, but also showed lung nodules with perilymphatic distribution. So with these findings, the combination of findings provided the suspicion of acute sarcoidosis or Lefgren syndrome. And indeed, we communicated that to the clinicians and they performed bronchoalveolar lavage, and this confirmed the presence of granulomas and lymphocytic alveolitis in keeping with pulmonary sarcoidosis. And then the patient was given oral steroids, and within a short time, soft tissue edema was resolved. So Lefgren syndrome, acute sarcoidosis, I like to put faces behind the syndromes. And this is a case of acute sarcoidosis, which was described back in 1946 by the Swedish pulmonologist Sven Lefgren. And it is quite uncommon initial presentation of sarcoidosis. Only 10% of sarcoidosis patients present with it as the initial presentation. And it has a quite favorable prognosis because it is usually self-limiting. The classical triad, which was described in 1952, included ankle arthritis, which was more common in men than in women, bihilar lymphadenopathy, and erythema nodosum. But in the era of ultrasound, it seems that the ankle arthritis, which was included in the classical triad, is not really arthritis because the swelling is caused by hypervascular cellulitis. This is the most common finding in acute sarcoidosis. There is also mild tenosynovitis in up to 40% of cases, whereas effusion in the joints, so arthritis, is quite rare, only up to 25% of cases. The clinical presentation is very non-specific. So the patient comes with pitting edema, which is a very general symptom, a very non-specific symptom, and erythema nodosum may or may not be present, as in our case, which was not present. Ultrasound shows hypervascular cellulitis, so fluid collections inside the soft tissue of the subcutaneous fat, which was hypervascular, and also mild tenosynovitis. There are no signs of significant fluid in the joints or presence of synovitis. And this is an important feature because it minimizes the possibility of rheumatoid arthritis or remitting seronegative synovitis with pitting edema, which is a condition which is usually found in the elderly and can cause pitting edema. And also the presence of no effusion in the joint minimizes the possibility that the joint the fusion around the tendon sheath is caused by communication of the tendon sheaths with the ankle joint space. Because as we know, tibialis posterior tendon usually communicates with the ankle joint as an anatomical variation. So I think this case is interesting because it emphasizes the crucial role of ultrasound in order to limit the differential diagnosis of a very unspecific, non-specific clinical presentation, such as pitting edema, provided that it is performed by a skilled sonographer who pays attention to details. Thank you for your attention, and thank you for having me here today.
Thank you so much. What a beautiful case. Our next speaker is Dr. Alexa Lopes. She's a practicing MSK radiologist and the coordinator of MSK imaging at Clínica Axial, Grupo Olhar, in Belo Horizonte, Brazil, for over 20 years. She graduated with a degree in medicine from the Federal University of Minas Gerais, and she completed a medical residency in radiology and diagnostic imaging at Hospital IPSENG. She did an MSK fellowship at Duke University and also a fellowship in sports medicine at La Sauvegarde, Lyon, in France. And she's interested in all areas of MSK imaging with emphasis on rheumatology and sports imaging. Please, Alexa, share your screen.
Is that okay? Do you see my screen?
Yes.
Oh, thank you so much, Hillary and Aline, for the invitation and for the kind introduction. It's a pleasure to be here once again. So let's move on. Let's get started. My case is about a 20-year-old female suffering from intense acute lower back pain for 2 years, lasting for 1 month, without significant relief with NSAIDs or with rest, complaining also of malaise and weight loss. She denies trauma, diabetes, or fever. She's got a past history of anterior chest wall pain, and her mother has lupus. On physical examination, there was no arthritis nor articular limitation. And she complains of plantar erythematous, scaly, and pustulous lesions on the right foot and scattered around both ankles, as you can see here. Lab tests showed elevated ESR and RCP, and the other rheumatological exams came out negative, the specific ones came out negative, and she had also elevated platelets and a polyclonal increase in gamma globulins. She had done an MRI in another institution, but we couldn't have access to the images, which was very disappointed. And but the good news is that the MRI pointed out some abnormalities in the left iliac bone and the sacroiliac joint. So a pelvic MRI was requested, though. On the coronal stir images, you can appreciate the abnormal left iliac bone with extensive bone marrow edema and soft tissue edema going from posterior to anterior. T1 weighted images show better the hyperostosis due to new bone formation. And we can also appreciate how swollen is the bone, is the left iliac bone in comparison to the normal side. The coronal stir images, we can see the periosteal reaction, how the cortical bone is irregular, fuzzy, and the bone reaction and soft tissue reaction along bone. And also some involvement of the sacroiliac joint and the bone marrow edema as well. Besides, a very important mention is that a lot of erosions scattered along the periphery of bone and within the hyperostosis, in between hyperostosis. Gado post-contrast images show strong enhancement of bone and soft tissue edema, and we can also appreciate the involvement of the sacroiliac joint, better seen on this high resolution vibe sequences in order to show better the subchondral erosions along the iliac side of the joint. CT images highlighted the structural damage and show better the hyperostosis, the erosions, the bone reaction, and also the scatter erosions inside in between the hyperostosis. Well, a bone scan show the remarkable high uptake into bone, and also showed some faint uptake into the sternoclavicular joints over here. She had, as I told you, she had a past history of anterior chest pain, so there was some sign of this in this bone scan. Some diagnostic possibilities were suggested, such as infectious sacroiliitis, psoriatic postulotic arthroostiitis, chronic non-bacterial osteomyelitis, and SAPHO syndrome. And the diagnosis was SAPHO syndrome, which is a rare autoinflammatory disease reported by a French group in 1987 that stands for synovitis, acne, pustulosis, hyperostosis, and osteitis. The actual incidence of SAPHO is unknown. It's probably much higher than it is expected. It has a prevalence of 1 to 10,000 in Caucasian population, and it has a predominance in middle-aged adults. The pathogenesis of SAPHO is still not fully understood, and it's likely a combination of genetic, environmental, and immunologic factors. Currently, the term SAPHO functions as an umbrella term, covering many other diseases that share some clinical related symptoms. Well, the SAPHO syndrome, the diagnosis is clinical. The anterior chest pain is the most frequently site affected by the disease, followed by the exoskeletal, the peripheral joints, the clavicle, the mandible, and there's also dermatological involvement. It's a characteristic of the disease. It's a key point of the disease and is observed in 60 to 90% of cases. So we have to think of SAPHO when we have a systemic disease together with osteoarticular and cutaneous symptoms. The MSK findings are, as you could see through this case, hyperostosis, osteolytic lesions, osteitis, involvement or not of the sacroiliac joint, and enthesitis. The skin manifestations, they varies from vulgar psoriasis to palmoplantar pustulosis, which is the most affected skin lesion. If we go back to our case, we can meet all the diagnostic findings of SAPHO syndrome, such as the hyperostosis, the bone marrow edema, which in this case means osteitis, the periostitis, the periosteal reaction, and the erosions, and also the synovitis and sacroiliitis that is seen in this post-gadolinium imaging. There is a very interesting and very characteristic bone scan sign of the disease when it affects the anterior chest wall, which is called the bull sign. It's very typical, and you should think nuclear medicine. We have to think of it when the nuclear doctor calls our attention about it. What is the role of imaging in SAPHO? Well, since there is no laboratory finding specific for the syndrome, We as radiologists, we're going to help a lot the clinicians because the imaging methods, they play a potential role in the diagnosis and management of the syndrome, adding clinical value and lab findings, adding value to clinical and lab findings. Bone scan can show the characteristic pattern of bone uptake and other signs of involvement that can be also shown by PET-CT and whole body MRI. Treatment, there are so many options that comes from NSAIDs to biological therapies, and it seems, according to the ultimate literature, that the biological treatment is a viable alternative for those patients who do not respond well to conventional treatments. It's coming to the end. So I have to leave it to you. This key message, I think it's very important because it's a rare disease. So we have to think of it in patients who present with worsened acne, polyarthralgia, widespread bone sclerotic lesions in imaging studies, in a young adult. And it's important to consider and recognize SAPHO syndrome. I think I'm done. It's okay. I'm finished. Hope you have liked it.
Thank you. That was a beautiful case. Very
I
dramatic.
hope you would like it, Hillary.
Okay, now it's my honor to introduce my friend, Dr. Girish Gandikota, who's a professor of radiology and rheumatology at the University of North Carolina, specializing in musculoskeletal radiology. He obtained board certification in the UK in both surgery and radiology, and subsequently completed musculoskeletal radiology fellowship training in Canada at McMaster University in Ontario. After that, he joined the University of Michigan as a lecturer. He holds his American board certification and obtained ultrasound RMSK certification from, there's a lot of letters here, APCA and ARDMS, which I'm sure is a thing. Since 2022, he's professor and vice chair in the Department of Radiology at the University of North Carolina. He's a winner of Excellence in Teaching Awards. He's been an invited speaker, delivering more than 350 invited lectures and national presentations. He has so many scientific papers and exhibits, and his main research interests are MSK ultrasound, sports medicine, and arthritis. He conducts CME courses on MSK radiology and ultrasound, both in the US and around the world. He's a co-investigator on NIH grant research project in arthritis. He's mentored many residents, technologists, and medical students. He also has multiple administration roles at the University of North Carolina and at the national and international level. He's a reviewer for multiple esteemed radiology and rheumatology journals, including Arthritis and Rheumatology. And that's why I invited him to speak today, because he's such an expert. Okay.
All right, thank you. Thank you so much for the invite. I'm very happy and honored to be here. I hope you're not seeing that window that's popping up on my screen saying installing update.
No.
Yeah. Okay,
no,
perfect.
looks good.
It's just my problem. We'll deal with it. So I'm going to talk on enthesitis. Now, I'll take a slightly different way in this one, in the sense that I will actually show you 3 problems that you are likely to encounter where you have to at least think of enthesitis. And then we'll go a little bit deeper into what that means, okay? So in terms of disclosures, nothing. So moving on. So when do enthesophytes indicate enthesitis? So that's probably the first question we will deal with. Like, for example, this is bothering me a little bit. Okay, so this is the patient. This patient came with ankle pain, and you can see that there is a plantar calcaneal spur, which is fine. But the Achilles tendon enthesophyte is big, huge, and not so good because of the loss of crispy outline, at least in the inner side of the enthesophyte. And you can also see some subchondral sclerosis happening along the superior border of the calcaneum, basically where the retrocalcaneal bursa lives. Now, this particular patient came back 6 months later with this kind of findings. Now you see there is bone resorption here, bone proliferation here at the plantar fascia attachment site, and 6 months further down the line, it's all cleaned up. So we'll talk a little bit more about enthesophyte versus enthesitis. The other thing is always this confusing part is, when do you diagnose synovitis and when are you over-diagnosing synovitis? Because the treatment for the conditions that cause enthesitis and the conditions that predominantly cause synovitis is quite different. If you do not adjust your power Doppler, as seen here, and if it is a little bit more sensitive and there's more artifacts, it kind of bleeds into the surrounding areas and almost feels that this is a synovitis. But as we will notice later on, this actually was a capsular abnormality. In fact, if you look at the video, there is a big osteophyte here. There probably is a small amount of effusion too, but that particular bone does not look very healthy. It is irregular, and that's one of these locations of enthesitis. This patient was wrongly diagnosed as synovitis, was actually enthesitis. We course corrected it a little later. So we'll talk a little bit about that. And the other thing is the common question of when do you call it tendinosis and when do you call it enthesitis? Majority of the abnormalities that we see in the Achilles tendon and plantar fascia are going to be tendinosis, but these are also very common locations for enthesitis. And it is often the radiologist or whoever is scanning, you will have to make that call based on the history because there will be trauma for both. It's just a little less significant, in these cases where a minor trauma can cause a major reaction. And we'll talk about that also for a few minutes. So enthesophyte, enthesis versus tendinosis versus synovitis. What is enthesial organ? I'll briefly touch on that and a couple of examples of ultrasound and MRI, and I've already shown you that. So first, some background. Right from long time ago, in the 1980s, 1990s, we have always been thinking, at least one of the ways we have been looking at arthritis is it primarily synovial, like rheumatoid, or is it primarily enthesial, like the spondyloarthropathies kind? Now, we have added in this list crystal deposition disease as well, because any deposition of crystals will, some places at least, activate the inflammasome pathway locally and cause some destruction. And of course, there is this new immune therapy activated arthritis, which is taking over a little bit. And we need to talk about that maybe a little later. But today I'll be focusing on primarily synovial and more likely primarily enthesial. So these are the conditions which will come under spondyloarthropathies, which you all know. And these are the usual findings, and they are enthesitis, dactylitis, which also includes enthesitis of a digit, so-called sausage digit, a nail disease, which also, by the way, is a version of enthesitis, spinal inflammation, and it also has enthesitis there in the areas of syndesmophytes and anterior long-term ligament attachments, which we will not be talking today, and also synovitis. Now, the question is, how common is synovitis or enthesitis in spondyloarthropathies? And how big is it? So they did this study where they looked at the MCP joint of people presenting with RA and people presenting with psoriatic arthritis. And the enthesitis, if you look for it, was present in about 54% of the joints of the patients with psoriatic arthritis, and only 2.5% of the joints in patients with early rheumatoid arthritis. So there is a significant amount of enthesitis. We just need to look for it. Many studies quote the presence of enthesitis to be 30 to 50% in, say, psoriatic arthritis early on in the disease. In fact, early bone formation is also the bone formation that you see, the dirty bone formation, that is also pretty much an early finding. Synovial involvement is significantly limited or at least lower to begin with. So we know what is an enthesophyte, right? It is this osseous prominence at the attachment site of the tendons mostly. It is a response to stress, does not indicate enthesitis, and is mostly asymptomatic unless if it is fractured or there is history of trauma. But we also know that once we start losing the crispy outline, once there is bone proliferation or bone resorption, we want to comment on those enthesophytes. So enthesitis and enthesophytes can coexist if you have one of these three findings associated with an enthesophyte. Moving on to enthesis. Now, what is enthesis? It is a site of insertion of not just the tendon or ligament, but fascia, retinaculum, articular capsule, everything around the bone. And this is an old concept described constantly from 1970s onwards. It is nothing new. We know about this, and we know that there is arthritis associated with this. It's just that the imaging helps us to look at these things a little bit more in depth now compared to before. So what are the enthesis types? Now, there are two types, fibrous and fibrocartilaginous. We will not get into the fibrous type, but generally the enthesitis are restricted to fibrocartilaginous types, which are in the epiphysis and epiphysis. And these are the ones which have got 4 distinct zones. Now, we don't want to remember that, but it is those zones where there is tendon. Then you have unmineralized fibrocartilage, mineralized fibrocartilage, and lamellar bone. It's really the fibrocartilage which you would like to remember, and this fibrocartilaginous enthesis which causes the enthesial change. Now, every enthesis will undergo trauma, and if they do undergo trauma, they will heal, or there will be tear, or there may be tendinosis of the adjacent tendon. That's quite normal. But in some susceptible individuals, the immune response gets accelerated, as with everything in life, whether it is cardiac or otherwise. It does not know when to stop. The healing process is not controlled, and you get this process of inflammation overtaking the healing, and that's when you get enthesitis. So it happens in some susceptible individuals. Trauma probably is there on both cases. So what is enthesitis? It is inflammation at the site of the tendon, ligament, and capsule attachment site. This is a picture from Dr. Rexner's book a long time ago demonstrating this. So we know that there is inflammation. We have pathological specimens confirming that. What exactly happens here? Right? This is from McGonigal's article in 2017, where you can see that the muscle and the tendon is attaching here. So this is the enthesis, and enthesis does have small vessels, right? And these are called the transcortical microvessels. When you have an injury, there is a stress sensing by the bone, and then it will try and heal. Now, while healing, there will be some vasodilation, so prostaglandins are released. But when it is abnormal, the neutrophils get into this enthesis, stimulate these mesenchymal stem cells to overproduce the bone that you see. And that is the problem. And there's a lot of research going on as to how this is, why is this happening? But more importantly, how can we protect it? And you will realize, maybe in this case, and we'll not get into depth too much, but these things, the mediators that cause this inflammation, the PGE2, and that's why the prostaglandin E2, that's why the NSAIDs work great with enthesitis, not so well with synovitis. So this one, I interleukin 23 and 17, and the tumor TNF, the drug therapies are based on these particular mediators. So the bottom line is we have to try and differentiate enthesitis and anything else that is going on around it. The synovitis responds very well to DMRDs, but not enthesitis. So there is a slight difference in the way we treat these things. And this is the EULAR recommendation for psoriatic arthritis, where I'll just take one thing, like the enthesitis here, you treat with NSAIDs, and then it goes to phase 3 treatment. If that is not under control, DMRDs are out, and interleukin, TNF inhibitors, and everything else. So that the medicine is quite different in which you go ahead with this. In terms of enthesial organ, a quick word of that, right? So this is the Achilles tendon attachment site here. when you have an injury to the fibrocartilage attachment of the Achilles tendon, it can initiate an inflammatory response in susceptible individuals, which will involve the synovium, adjacent synovium, and fat pad, and so on. So the Benjamin and McGonigal, they coined this term, synovio-enthesial complex, and you will see in multiple locations. One of them is, of course, Achilles tendon, where you have an injury here to the fibrocartilage, and then you also have irritation and inflammation of the retrocalcaneal bursa and the edema of the adjacent fat pad as well. Now here we can revisit that question. How do you tell the difference between enthesitis and tendinosis? And it is quite difficult and very much dependent upon the history and trauma and everything else. But one of the things that they were trying to define is that if the blood vascularity almost touches the bone or is in close proximity to the bone, you at least should think about enthesitis. If you have a tendon which is horribly bad all the way through and through like this, with calcification, vascularity everywhere else, it's probably tendinosis. In terms of ultrasound, again, there was a lot of interest in ultrasound for a while, and then the OMER Act has defined this enthesitis. We will talk about that. We already spoke a little bit. The main thing is that the blood flow is within 2 millimeters of the bone. So the closer it is, the better it is. Now, what happens? Here it is, the soft tissue abnormality next to the tibia. In this patient with psoriatic arthritis, you see the increased vascularity. You see the periosteal bone proliferation. So there is bone proliferation. And there is bone resorption at the attachment site, almost like an erosive change at the flexor digitorum longus. Okay. Now, it also has got the other thing, which is the ligament vascularity. It is much more present in the ligament than the joint itself. And one of the other things we have noticed is that there is increased vascularity in the tissues around the tendon. The tendon itself, there's no tenosynovitis or no tendinosis, but there's increased vascularity and hyperechoic change in the soft tissues around the tendon. So look for those things. And this is the one I was talking about. Look at the bone irregularity, capsular thickening, increased vascularity. This one is enthesitis. This is not synovitis. So you've got to be careful when you look at these at a minutiae level. Is it really more of synovitis, or is there some enthesitis as well? Now, the enthesitis can involve structures like fascia, peritoneum, as demonstrated here. But the most important thing I would like you guys to take home is that if you see a plantar fascia, it probably is plantar fasciitis or plantar fasciosis, but at least think of enthesitis in the right clinical context. That is how they will present. In MRI, we all know there is a huge amount of edema. Edema is disproportionate to the changes in the tendon, and this edema is even actually more than what you will more likely to see in, say, trauma, and there is quite different. So you will see soft tissue as well, and you will see this edema in the bone and a tiny amount of increased signal at the attachment site. And the same is the case with this enthesitis of the lateral collateral ligament. This is not trauma. There's edema going way beyond that. And the type of edema, if you see 20, 30 of these, you may be able to easily tell the difference between a enthesitis type of edema and a post-traumatic one. This is an example of bone edema at the retinaculum attachment site in this patient who was treated. And within 10 months, the edema has disappeared and it is gone. But just wanted to highlight that it doesn't have to be tendon. It doesn't have to be just ligament or capsule. It can be even at the fascia and the retinaculum attachment site that you tend to get these enthesitis. So in conclusion, make sure that you look at the enthesophyte and make sure you look at the crispy outline. Is it still preserved or not, especially in Achilles tendon and plantar fascia? And if there is bone proliferation and bone resorption, call it. Fibrocartilaginous enthesis is the one which is involved with all these kind of enthesitis. With the mediators we talked about, the highlight is that the treatment is quite different from synovitis, so it is better that we identify these things correctly. And of course, dactylitis, nail disease, vertebral inflammation, there are versions of enthesitis, and there are papers suggesting the more the nail disease you have, you probably have enthesitis elsewhere as well. And in ultrasound, when you're doing so, it is easy to go fast and say, hey, this looks like soft tissue thickening in the joint, and it is probably synovitis. Just make sure that this is what really synovitis, or there probably is some enthesitis as well. And always look at the ligaments. Sometimes in the deltoid, you will never put Doppler, but try and put Doppler and make sure that there's no vascularity, or at least around the tendon, there probably is some vascularity as well. And then MRI is very good. You will see a lot more edema than a normal trauma, so you should always suspect that. So not everything is post-traumatic. So it's really, this talk in this case is about think enthesitis in these situations. Thank you so much.
Thank you, Girish. It's always beautiful to see those images. You make it seem easy. I just, I wonder, when you're faced with a case of Haglund's deformity, how do I know it's something, that it's just Haglund's deformity and not something else?
Yeah, so I think with Haglund's, if you have a cause for the abnormality, you will probably go down that path, and 95 out of 100 times, that will be the right path. But if the person is not very active, the patient is known to have spondyloarthropathy, and now we are having issues with Haglund and elsewhere, you probably will then realize and say, you know what, this looks like Haglund, but in this particular context, I think medical treatment is far better than doing surgical. So I think that is the way to go with these things. There's really no imaging exclusive findings to say that this is enthesitis and this is tendinosis and bursitis.
Right. Thank you.
Girish, for those who perform ultrasound and use the Doppler, what would be the parameters, like quick tips for the Doppler parameters, not it to be very sensitive, like you showed? What would be the PRF and etc.?
Yeah, so there are numbers, and I don't go by the numbers, but if you increase the Doppler gain to a level that you start seeing the aliasing, and then reduce it a little bit so that you don't see the aliasing and you don't see any vascularity deep to the bone, cortex, and so on. So that may be better in that sense. And also, you will get the feel of the vascularity, because nowadays the grayscale imaging is really good. And when you see that and say, hey, this is where I think the vessel is, and this is all we should be seeing the vessel. So you can adjust based on that too. But what I have seen, especially when this happens when we don't directly scan these cases, is that the Doppler is pretty much at a higher level just so that we pick up everything. But what that does is that bleeds into the soft tissues adjacent to the capsule. The capsule is millimeter thicker. So, and then you start thinking everything is synovitis.
Thank you. I don't see any questions from our audience. Do you have any questions, Hillary?
No, I was just curious again. There, you had a little histologic image where of the posterior calcaneum, labeling
Yes.
the different types of fibrocartilage. What were they labeling sesamoid fibrocartilage at the calcaneum?
Yeah, so a lot of articles are also rheumatology based.
Yeah. I figured something like that.
So I think they use the terms interchangeably in some of these cases, but anywhere where the sesamoid is, they feel like there is a fibrocartilage closer to that, or attachment is one of those things where you can see inflammation.
So I have a question. Maybe we're misusing the terminology. I know that my colleagues and I talk about incisional enthesophytes and intrasubstance enthesopathic ossification. Is that a thing? Or is that just dystrophic calcification in the setting of chronic tendinosis?
I think so. I think the second one is correct. And enthesophyte, by definition,
is insertional.
Correct.
Okay.
Just what insertional can be debated, like ligament, fascia, whatever, it has to be at that level.
And if you see those, typical anterior, superior, inferior patellar enthesophytes we see all the time, if they're smooth, do you report them?
No.
Okay.
No, because I've noticed that I do all these rheumatology conferences, and It takes me a little while from July to August to September to tell the difference and appreciate the difference between enthesophyte and enthesitis. So
Right.
it is better to not confuse if that is not going to change anything.
Okay,
But
good.
if it's fractured or something, you will talk about it, of course. But yeah, I usually don't mention that.
Okay, thank you.
Okay. No more questions. So thank you all for tuning in today. The next session will be on June 21st. We focus on sports imaging. Thank you all for joining us. See you.